Good afternoon, everyone. Thank you for joining. People another second for their audio to connect. But welcome everyone to the working session on the consent management application, supporting the implementation of Chapter 798, House Bill 1375, Health Information Exchanges, Electronic Health Information Sharing and Disclosure. So before we begin with today's working session, I have a few housekeeping notes. So if you experience any technical difficulties during the call, please contact my colleague, Justine Springer. Her email address should be in the chat already. Today's meeting is being recorded, and we are looking forward to having a robust discussion during today's working session. But until we get to the discussion portion of the meeting, please remember to mute yourself. So we will not be holding a formal roll call today, but we are really excited to welcome around 81 people who've registered for today's meeting, including individuals from 15 HIEs and 10 EHNs. And since we're not going to go through a formal roll call during the discussion portion of today's meeting, please introduce yourself and your organization. You're also welcome to update your name that appears on Zoom and indicate your organization if you would like. We've noticed sometimes if you receive the registration link from someone else, you may have entered the Zoom under someone else's name, so please check your name. And the chat feature for today's meeting is on. However, we encourage attendees to participate in the discussion portion. And we also encourage folks to please keep the discussion focused on the implementation of the law and the regulations. Now, before I begin with today's working session, I'd like to offer our Executive Director, Ben Steffen, the opportunity to say a few words.
Thank you, Anna. I want to welcome our 50 or so attendees. I also want to thank the MHCC staff, including David, Anna, and Justine for their work on implementing Chapter 798. In parallel, as many of you know, we've also been working on implementing House Bill 812 passed in 2023, which covers the protection of reproductive health data. We've managed, I think, to integrate the work pretty well, giving 812 preference as requirements to implement that law are much more the timelines are much shorter. Our attention, however, hasn't been lost on the legislation that passed in 2021. I will note that there will be 3 meetings. This is the first, and I'll look forward to some thoughtful comments. We want to move forward, however, with these now that we have moved the 812 changes into regulation. So thank you, everyone, for attending, and I'll look forward to some fruitful and productive conversations. Go ahead, Anna.
Thank you, Ben. We also have with us today David Sharp, our Center Director. David, do you have anything you would like to share as well?
Only that many of you may remember how we've used similar approaches on other regulations as we've gone through the informal development of them. And so as a working session, what you're going to be seeing today are elements of the consent management application component in the section in the regulations that as an informal draft, we've tried to take into consideration comments, and we'll have some specific questions for you all to give us your feedback on. And if there is anything that you wanted to say that we weren't able to get to, if you can either put it in the chat and we'll be sure to review them all following the meeting, or you're welcome to send us an email. This is a work in progress, and we're not necessarily thinking we're walking today with having this section, this informal section being specifically defined and ready to advance forward. We're going to continue to work on it over the summer as necessary. So again, thank you for joining, and we'll get started. Anna, back to you.
Thank you, David. All right, so let's begin with an overview of the law. As we mentioned, Chapter 798, Health Information Exchanges, Electronic Health Information Sharing and Disclosure, it passed during the 2021 Maryland legislative session. And the law establishes requirements for the state designated health information exchange, CRISP, to develop and maintain a consent management application, or I refer to it on the slides as the CMA. The CMA must allow a person in interest to opt out of having electronic health information shared or disclosed by an HIE, and inform a person in interest of the electronic health information that may be shared or disclosed, notwithstanding the choice to opt out. So currently the process for consumers to opt out varies, and it may require submission of multiple requests to different sources. So while consumers, they recognize the need for and real benefit of electronically sharing health information, they want and expect to control who has access to their health information. And the CMA aims to centralize that process for healthcare consumers to opt out of having their health information disclosed by an HIE. So the law also requires health information exchanges operating in the state to obtain the opt-out status of a person in interest from CRISP before sharing or disclosing their electronic health information. The law also prohibits the HIEs from sharing or disclosing the health information of a person who has opted out. And the law also allows for penalties for non-compliance. So as we mentioned, we have regulations that we're going to go through today. And just to provide some background, in May 2023, stakeholders submitted comments on the draft amendments to COMAR 1025-18, Health Information Exchanges, Privacy and Security of Protected Health Information, in support of Chapter 798. And as Ben mentioned, efforts to update the regulations to align 798 were put on hold as priority was given to emergency regulations and implementation of Chapter 249, House Bill 812. So when drafting the CMA specific regulations, the MHCC sought input from various HIEs on possible approaches. And most stakeholders we spoke to recommended the regulations provide non-technical guidance to ensure that there's flexibility in design and development of the CMA. And a recent version of the regulations were released for public comment in May of 2024. So as we mentioned, some of the goals for this working session specifically are to discuss the select comments pertaining to the consent management application provisions in the draft amendments to 1025-18 and consider possible strategies for implementing the CMA that include a blended approach of both building on technology and current user policies. So during the discussion, we're seeking feedback on the CMA specific regulations and clarity on the select comments provided by stakeholders. And we may not reach consensus on all approaches, and we understand if there's concerns with the statute requirements, but the goal for this meeting is to solicit input on the specific regulations. So we will also host additional working sessions, as Ben mentioned, in July on other provisions of the draft regulations. So on the 23rd, we will discuss amendments specific to the reporting of non-controlled prescription drugs to CRISP. And I see we have many dispensers on the call today. I think y'all are going to find that working session particularly interesting, and we look forward to your input on those regulations. And then on the 30th, we will discuss the reporting of electronic health care transactions to CRISP. So moving forward with today's goal of discussing the consent management application, before we jump into the regulations, I wanted to discuss briefly the phased approach that's proposed in the regulations. So this is a summary of what's taken out of the regulations, and we're going to share our screen soon so you can see them in more detail. But the phased approach proposed includes the phase 1 of CRISP implementing a register, a database or repository to serve as the consent management application, and that will store personal identifiers and minimally support downloading by other HIEs. In phase 2, CRISP shall implement data feeds using industry standards that support at least weekly data deliveries from the consent management application to HIEs. And in phase 3, Chris shall implement a consent management application with an API that enables a standardized way to facilitate interoperability between different HIEs. So as I mentioned, we released the regulations in May. We received around 32 comments on the consent management application provision specifically from 6 organizations. And we appreciate everyone who reviewed and provided comments, and we look forward to discussing them in more detail during today's meeting. So shortly, my colleague Nikki Majewski is going to pull up the draft regulations. And while she has them on the screen, I'm going to read a summarized comment, and Nikki will have the corresponding regulatory language on the screen. So then we'll discuss the feedback and consider modifications to the regulations. And Nikki will add comments or amend the regulations as we discuss them. All right. So Nikki has up COMAR 1025-18, specifically Regulation 1, Section C, is where we're going to begin today. So the first comment we wanted to discuss today is an overarching comment regarding the implementation of the consent management application. And the question we received was if we could clarify whether the opt-out applies to the system or the HIE itself. For example, does information need to be withheld from disclosure if a patient opts out within a healthcare system? And so we wanted to direct people to this portion of the regulations, which were not amended in the draft regulations. And it specifically calls out the situations that the chapter does not apply to, including the protected health information exchanged, accessed, or used or disclosed between a hospital and a credentialed professional, among credentialed professionals of a hospital's medical staff, between a hospital and its affiliated ancillary clinical services, among entity under common ownership, by a carrier, or between a carrier and its business associate. So we understand the question about when does the opt-out apply regarding the consent management application. Are there questions related to the applicability of the consent management application that aren't addressed here?
And Anna, if you want to sort of remind folks the best way to get their questions raised, is it just sort of talking up or raising the hands? How do you want to proceed?
Yeah. How about we have people jump in if they have a comment or a question to add. And I will look for raised hands as well, if you prefer that.
Give it a moment or two. I think it does clarify where the opt-out applies and where it does not. And I think, as Anna noted, the existing regulations help to clarify when an opt-out does not apply. Okay. Seeing none, and again, if you have afterthoughts, we're happy to take them, so don't feel like you've missed your chance if you're still noodling over it. In an effort to keep the momentum, we'll continue forward and happily come back as necessary.
All right, Nikki, so next we're going to Regulation 3, Section A. So we received a few questions from commenters that we wanted to address. And this is in regards to when a consumer has the right to opt out from having their data exchanged or accessed via an HIE. And there were questions if we could clarify that further. So Regulation 3, Section A or anything maybe a little bit further up. So Regulation 3, Section A discusses the rights of the healthcare consumer, and then subsection 2 talks about when the consumer has the right to opt out. And then underneath that in paragraph A and subparagraphs, it discusses that a healthcare consumer has the right to opt out of an HIE at any time and refuse access to the patient's protected health information, except when the disclosure is for those listed situations. So kind of going back and reminding everyone what the question is we received: when does a consumer have the right to opt out from having their data exchanged or accessed? Now, are there what elements of 1025-1803A2A could be clarified? And are there specific use cases people have in mind that they want to talk through in regards to the consent management application?
Okay, I don't see any just yet. I think we have a comment in the chat. Nicole Sweeney. Okay. So yes, good afternoon. So I'm not seeing anything here, and we really haven't hit the thorny stuff just yet. So if you don't have a comment now and something comes up later, we'll come back. Anna, welcome to proceed.
All right, so Nikki, we are going down to the consent management application portion. So that's Regulation 3, Section D.
So and there was a comment and that appeared in the chat, which states, how is the designation performed? My suspicion is you're referring to the designation of an HIE. You know, HIEs are at the beginning of the regulations. There's a definition of, it's really taken from the law that defines what an HIE has to meet in order to be, an organization has to meet to be considered an HIE in the state. So I would point you to the beginning of the regulations in chapter 1025-18 for that answer. Oh, you're saying no, other provider as designated. I'm not sure if we can locate, I'm not following your question. Are you able to speak? Maybe.
Yes, it was in, sorry, it was in the section that was just covered.
Okay.
Other provider as designated. So item 3, results of a diagnostic procedure sent to the healthcare provider. Oh, it went away.
Yeah, you had it there. So, okay, right there. Oops. Well, back to where you were, if you can. I don't see it. It was highlighted. There we go, right there. So your question is results of diagnostic procedures sent to the healthcare provider who ordered the procedure or another provider as designated by the ordering provider. So, so the question is specifically, what is another provider, or can you restate for me?
So it explicitly excludes releasing information to another provider as designated by the ordering provider. So is that understood to mean, like, say, partners in the practice? Is that understood to mean a covering physician or provider who's maybe on call? Like, or does the designation actually have to be formally documented in order to qualify for this exception?
So I guess the basic answer is it would most likely be, because if you are referring a patient to a specialist and you're sending a copy of that lab result to that specialist, it would be part of the care delivery, and the patient, part of the treatment, the patient wouldn't have opted out at that stage, because that's why it says except when the disclosure is limited to. So essentially it's noting that these are not elements that get opted out. If the patient says, I don't want to participate in a broader health information exchange sharing of my data.
So this particular clause applies to that specific use case or can be applied more broadly to other use cases?
Absolutely can be applied more broadly. I was just using an example.
Okay.
Great question.
Roberts has a similar question regarding diagnostic. Does it include just the order, but the result as well?
So so I think what I would say is we have to look at it at a broad level, because it says, except when a disclosure is limited to results of a diagnosis. So, the order, so it's kind of hard to respond to that, because the order would come from the primary care provider or the specialist. And that result could be sent to another rendering provider. So I'm not sure I'm able to follow your use case specifically.
So when I say diagnostic procedure, I feel like that's pretty clear. That is an order for a test or a clinical action that has a corresponding result to achieve a diagnosis or rule out status of a condition, etc. And so you're saying to interpret it more broadly, and you say accept a result. So it makes it sound like I can have a procedure and not a result. And I also understand the nuance of how that information can be proliferated. I feel like the language isn't really clear and it would be easy to run afoul. And I think, was it Dixie who just had a suggestion about maybe cleaning up that wording?
So why don't you tell us what you think, and we'll put it in what we call track changes, as you are familiar with, and we'll come back to it. So what is specifically here you think we should enhance? What would you do?
I will, you know what? I will think about that during the course of our conversation today and make a suggestion and ask others to weigh in as well.
Perfect. We'll highlight this and to come back to it. Okay, Anna.
Thank you, everyone. I'll give Nikki a second to write it out, but as she's working on that, our next set of comments that we received were more specific to the consent management application regulation language, which starts in regulation 3D. And the first more overarching comment we wanted to discuss was one we received, in which the regulation should also specify that it applies to a generic patient opt-out rather than specialized circumstances that require more specific authorization from a patient. Thinking about 42 CFR Part 2 and reproductive health disclosures.
Okay, so why don't we give Anna restate where you want Nikki to be? I think
I'm getting there. I'm sorry, guys. This is
okay.
a long document. I think I got it right here.
I think we're gonna go down to 3D, Nikki. So where the track changes start. Yeah.
23.
Sorry.
There we go. And this is a comment that's kind of overarching for this whole section. So you're in a good place, Nikki. So again, the commenter recommended that this specify opt-out are for generic opt-outs versus more specific circumstances, such as 42 CFR or reproductive health disclosures. So I guess the question we have for the group are there additional specifications that are needed in this section to account for those types of circumstances described? I can give people a second to read kind of the beginning part of the section.
So Anna, why don't I ask you to restate the question a little differently for the group? Is it that we want to look at what each item, or is there a specific question that relates to one of the items, or was that just a general comment overall to D1?
I guess it would be helpful to hear from the group if there's specific language that they would like to see in this section that would help account for those specific circumstances, such as 42 CFR Part 2 or reproductive health disclosures.
And then
Looking at the comments.
Is the use of the term electronic health information intentional to work off the federal blocking language? I wouldn't necessarily tie it to the information blocking rule, although that is a fair assessment to make. So let's just restate what's here so we're all sort of aligned. So the consent management application, the state designated HIE, in this case Chris, will implement the CMA that allows a person of interest to opt out. It's me as the individual or the person who, if I'm the family caretaker or guardian, to opt the person out. It also informs the person of the types of electronic health information that may be shared or disclosed. So there's the educational piece. And it also enables an HIE to query whether a person in interest is opted out or back in. So if we think about it, it would enable the participating HIEs who are connected to the consent management application to have an ability to check to see if that person is opted out or to be able to determine when that individual has opted back in. And those would be important components of the functionality of the HIE.
I have a question. Do you have a specific wording to describe exactly what this includes to the patient? Or are you going to leave it up to the different HIEs to come up with their own wording?
So on the consent management application, Chris will actually develop the consent management application. The way the regulations are constructed today is that there's a consumer education requirements, and it would be up to the HIEs to define specifically, how that works for that HIE. Great question. Thank you. Anna.
If folks have other thoughts as we're moving on about additional language regarding sensitive health information, feel free to add it to the chat or let us know. But the next comment is also another overarching comment regarding the consent management application. So the comment states the integration of the consent management application and health information exchanges contemplated in these regulations will have a significant impact on EHR developers and correspondingly providers and health systems that license, configure, and use those EHRs. There may also be an increased cost to Maryland healthcare providers for this integration, as well as lengthened timelines for implementation. And we've heard a similar type of comment from a few stakeholders, and we were hoping during this conversation to gain a better understanding of what are the potential impacts of implementing the consent management application. And we're hoping those on this call can share a little bit more.
And while you all are thinking about that, I'll just highlight a couple comments, particularly from Nicole Sweeney and Chris, who probably most of you know. She's indicating that Chris is eager to work with interested parties that will be co-implementing this application with Chris. And she's inviting interested organizations to reach out to her to talk about possibly piloting a production component or an element of implementation. So if you're willing to get engaged at that level, please contact Nicole Sweeney. Okay, are there other questions or any questions related to this section?
Yeah, this is Pamela Rain from Hopkins. I had provided comments on C. I think, and it goes kind of to the comment that was made previously about the burden on EHR developers and potentially providers. I think the way that this should work is the HIA shouldn't be querying this application management tool. It should be a push from the application management to the various HIEs once those connections are made. The idea of sort of requiring the the HIEs to do the query, it's just operationally very challenging. And so, we've spoken with Chris about this, and we think it can work where it's a push.
So that's interesting because some of the HIEs last summer had wanted a glide path, if you will, through the phases, where eventually it could be a push, or it could be a less technical way that they might want to have user policies around how folks could connect to Chris via their solution and review their database, if you will, of opt-outs and opt-back-ins. So while we promoted, we're looking for a technical solution, it didn't seem as though the HIEs could get to that stage at any time soon. So
no, David, I totally agree. I think the idea was in this section, this is not the phases. This is actually what you have to do. And so I think we wanted to keep this technologically vague or solution vague, as opposed to mandating a query. Maybe what I had suggested is something, you could be like readily ingest or incorporate into their system, the opt-out, or, query or receive, or something other than query, because to your point about the different phases and potentially having different technical solutions, we wouldn't want to be in violation of that provision if the solution we develop isn't a query.
I see. So it's really just a wordsmithing.
Correct. Exactly. Yes.
Oh, got it. Okay, that makes sense. We'll just note wordsmithing, Nikki, in the comments, and that will help us. And I think there was another question or comment being raised. So there is a comment here. It says, are providers in Maryland required to utilize the consent management application functionality to manage patient consent? So I think that gets back to the broad intent. If it requires the HIEs to enable it, if providers don't use it, then not sure how the patient's desires around opt-in or opt-out, opting out and then back in, would be communicated. So I think there would have to be some requirements among the HIEs of its users that this is built into the workflow in some mechanism, or providers could potentially, without knowingly, exchange patient information when the patient had opted out.
So would determine be a better, broader word to use here?
Enable HIEs to determine, yeah, I think so.
Yep, I love it, Ben.
Okay.
Okay, great. And again, thank you all for bearing with us. We're getting into our groove here. It's a little clunky, admittedly, but we're getting in sort of a process flow. For those who've been around for a number of years, this is how we've worked year over year, and it's been effective, but it does take us a little bit of time to get into the groove. So thank you for bearing with us. Anna, you want to take us on?
Sure, happy to. And I know there are other HIEs on the line. If as we're discussing, you wanted to discuss further some of the concerns with the consent management application, we're looking forward to hearing your comments. So Nikki, our next question or comment is right where you just edited to do. You don't have to move anywhere. So we received a specific comment that information that is pushed by healthcare organizations to CRISP through HL7 interfaces should not be considered an HIE transaction and should be out of scope for this requirement. Now, mechanisms are not readily available in HL7 to opt out specific patients. And since Chris will already be opting this data out from Exchange, there shouldn't be a need to include HL7 transactions in the scope of what should be opted out. So with this comment, we're hoping to understand why information submitted to Chris via HL7 transactions from providers be excluded. And maybe some of the providers on the call can provide a little bit more information about that process. Or Chris?
Okay, so I mean, I can speculate, and when we received this comment, we did speculate, but I'll just sort of share what our speculation was and see if anyone wants to react to that. The notion that HL7 is more prevalent on the administrative transactions. What claims clearinghouses use to communicate with payers typically is in an HL7 format. The concern here is that HIEs, the technology standards adopted by HIEs, aren't really taking full advantage of, or in some cases, HIEs don't use any HL7 transactions for an HIE function. So we were thinking that the user was, or the commenter was expressing concerns about form-fitting a transaction that is less commonly used by an HIE into an HIE's workflow. So that was our thinking, and if anyone has anything differently to share with us, please do. And if there aren't any comments at this time, we'll just continue onward. Okay, Anna.
Okay. So another overarching comment related to the implementation of the consent management application was that generally electronic health record systems were not designed with a consent management application in mind. And there will always be a need to rely on provider interaction to affect patient preferences and disseminate information. So the commenter recommended revisions that would allow the provider to perform the actions on the patient's behalf and to provide required information directly are needed.
So Anna, is there a specific reference to the reg that the commenter wanted us to look at?
So I think this is, again, another overarching comment related to the consent management application and its general implementation. I think it would be in D1 somewhere regarding a requirement.
Anyone that this comment was shared by on the call that might want to add some more clarity?
I don't think it was my comment, but I'll speak to it because I think there's a lot of it I agree with. I think the challenge when we're thinking about it from the perspective of how a lot of this interoperability occurs today is saying these consent laws they vary widely across the country. And in many cases, when an EHR system or something like, SureScripts, is in the middle of these transactions, because of those variations, so many of the things that we've done to account for the ideas of consent is to say, we can't centralize them in a service like the way an HIE might think of it. And so instead, what we've done is to say the right place, or the place, I shouldn't say the right place, but the place where those interactions occur are between the provider and the patient. And because of that, there isn't a technology checkbox even, or other type of thing that is occurring that can be passed around on the network. Again, because of those variations. What is considered consent in Maryland isn't the same thing as consent in Minnesota, isn't the same thing that's consent in California. And so as we look at those technology services when we're making these decisions or around how these consent applications start, we need guidance, or I think there needs to be additional guidance on how we handle those scenarios, because there might be a patient from Iowa who is walking into Maryland. So now how do I approach this? I'm feasibly not going to see an opt out. Do I have to ask them for an opt out in this scenario that I would then pass to Maryland? Now, does that mean there's expectations for that patient when they walk into their provider in Iowa that information isn't going to get shared? It's those types of questions that I think are all bundled up in that comment. And again, I don't think it was my comment.
Can I add to Justin? Because I had a similar comment, but different. But I agree with what Justin is saying. And I think one of the challenges is this idea that it's a bi-directional opt-out, that we as the provider or the EHR developer or the HIE would have to push opt-outs to CRISP. I think the idea is that we should continue to manage local opt-outs locally. And if a patient wants a global opt-out, we should make the referral to CRISP and have them manage the global opt-out. Because there are lots of situations, I'll say Johns Hopkins as an example, if someone doesn't like the treatment they got at Johns Hopkins, all they want to do is just opt out of us sharing our data with someone else. They don't want to opt out of all the HIEs. And I worry that communication will get garbled in the technology of pushing these opt-ins back and forth. So my preference would be to sort of allow for the HIEs to refer patients to the global consent management tool and reach out to CRISP and get the information on their website and things like that, as opposed to managing it locally and then having to push it.
So Nikki, are you able to record that in the comments box? I think that's an excellent point. So we should look to see how we can try to make some potential changes to this particular part of the regulation. I think that was, Pamela, that was an excellent way to sort of summarize it. Anyone have additional thoughts around what Pamela has suggested? Okay, Justin, thank you for getting this started on that track, and Pamela for your insight here. Okay, we'll keep moving forward, Hannah.
All right, so Nikki, the next comment is specific to Regulation 3, Section D, subsection 2, paragraph E, the timeline. So 3D2. So I think maybe, yeah, up a little bit more. Yeah, right there at the bottom of page 24. It's beginning of So the comment we received was the timeline proposed in the amendments are not technically feasible, specifically the 60-day time frame to implement the first phase of the state designated HIE consent management application, and the 90-day time frame to implement phases 2 and 3. So I guess we are looking for the HIEs on the call to share a little bit more about what that process will look like in order for them to be able to implement the phases, and if they have recommendations on a different timeline.
So there's the 90 days. So in theory, what it could is that you'd have phase 1, phase 2, and phase 3. And there would be a time period that would allow HIEs to sort of sequence through the cycle. When we had talked with some of the HIEs, there were several that thought that that they indeed would, as soon as these phases are developed, they would just move to it. And if CRISP were able to develop the phases before the regulations went into effect, some HIEs would say, oh, I'll pick phase 3 to start with. I'm not interested in phase 1 and 2. It would be more of a menu pick, where others who needed more time were opting to go with a less sophisticated way. is there a sense that a progression of phases is not needed from the HIEs, and that organizations could just implement at a phase 3 level? And there's a question from Laura to Chris. So Nicole, are you able to comment here?
I'm not sure I'm seeing it says if Chris was providing specification in phase 2, we would need 180 days to implement with customers. I think that's great feedback for us. Is there another question? I'm sorry if it is, I missed it.
Cole, is it possible for that Chris would choose, and you may not know the answer today, to actually make 3 phases available upon the go live with the whatever date the regulations become effective, or would there need to be an implementation timeline for the state designated HIE to implement these phases?
I don't have the precise answer to that question, David. I'm happy to talk to folks. I do think it's worth saying as a partial answer to that question, that at least as we were thinking about this, we were never thinking about it as, what are the words that I'm looking for? As like staged phases. At least if we can do that, possibly there, we might have some limitations from a time perspective that would require us to do the kind of lowest hanging fruit. But the goal and the overall idea, at least in our minds, is that there would be as many technology solutions available as possible, because what might work for one HIE or provider isn't necessarily going to work for all of them. So there's a convoluted answer. It didn't exactly answer your question. But it is our goal to make as many of these possibilities and solutions available as quickly as possible. Again, what that will take from a technical perspective, we're still working through, and it may be that, phase 1 is available a few months before phase 2. But the idea is to kind of put them all out there as soon as we can.
Okay, that's great. Thank you. Any other comments here for either us in terms of word changing, or in terms of feedback that we heard from Nicole and Chris?
I'll just say I think that flexibility is really important, because phase 1 may not work for some folks. And so having sort of that flexibility for what works for each HIE, I think is valuable.
Excellent point. Thank you, Pamela.
Can I ask a question about the phases that you originally named?
Sure.
Because I didn't read them as different phases of functionality. I read that CRISP is going to develop the CMA. In phase 2, they're going to provide data standards to meet weekly deliveries of the information. And then in phase 3 would roll out implementations with an API. Is that not what we're saying?
Yeah, but you're saying, yes, I think we are, but I'm not. There is a technical component. So if I could get you to restate your question, because each one of them has a different requirement on the HIEs that connect to it. So if you could help me understand, I thought I heard you say there isn't a technical requirement.
No, well, that's what I'm wondering. So in phase 1, they're developing the CMA. What is the technical requirement that the HIE would meet? And does that change then over the different phases?
So Nikki, can you scroll up a little bit, please? Let's keep up with where we are. There we go, a little bit more. Okay, thank you. So on phase 1, state designated HIE will implement the register, database, or repository. And in this case, as the consent management application stores information, it would allow for an HIE, let's think of it in its most simplest forms, it's a CSV file. It would allow the HIE to download that file and upload it in their system and present it back to their providers in whatever manner they chose to. But it would create this file that not only could you hit against it in CRISP for viewing, but you could also take that file and load it into your solution, depending upon how each HIE chose to implement it on their side for phase 1. And it gets a little bit more technical with each phase. In the second phase, it would be data feeds using industry recognized standards. So if a patient opts out of an HIE that's connecting to CRISP, that information would be able to be pushed to the CRISP, theoretically, consent management application. It would allow for CRISP to consume it, so it becomes more of a seamless or a technology solution that functions from end to end. And in phase 3, it builds on that technology to create a more standardized approach for interoperability between the systems. So you can think of phase 1 and phase 2 as more of the quasi-technical workarounds to having a full interoperable solution in place.
Thank you for that explanation. And I think that changes the comment that I had originally put in there. If we're looking at the development of possibly 3 different solutions, rather than just going to a single all-inclusive solution when that is available, that complicates things for developers.
So we'll put that as a comment. It's interesting because when we first started down this pathway probably a year ago with some of the HIEs, we were thinking of just that, Laura, was having it to be a technical solution. And a number of the HIEs expressed concern because they thought more of a graduated, tiered, time evolving solution would be easier for them to implement. So maybe there's a duality in that. If you can start with phase 3, then that's perfect. It's available. I think we're hearing from Nicole that ideally it would be each one of these options would be available at day 1. And if you need more time as an HIE to have a less technical approach, perhaps phase 1 it works for you better than, say, phase 3. So
I think we conceived of this as phase 1, 2, and 3 are additive. Is that right, David? I think we don't want to have a situation where phase 1 does not support the implementation of phase 2 and phase 3 and so on. Is that correct? I mean, if that's not true, we'd probably want to rethink that, because to the point that I think Laurel made, you wouldn't want to restart. We've got phase 1, but to meet phase 2, we're going to have to restart development to meet those requirements, and yet again restart development to meet phase 3. We conceived of this as incremental but additive development, not separate implementations that have to be restarted at each of these phases.
That's correct. It wasn't built that you have to start with 1 and then evolve to 3. It was, if you can, the best scenario was to start with 3. But if you needed time, this was a pathway to helping you to sort of do this on an incremental basis that worked for your organization. Okay, great questions. Anyone else have any thoughts here?
I did offer language for phase 3 that an API or other secure electronic interface. I think talking to our technologists, they said that API may not be the best technology at some point, and we may just want to offer some flexibility in what solution will work.
That's a great point. So we will we'll pick that comment up again and come back to it. We want to be a bit more agnostic, I think, Pamela, to your point.
Exactly.
Great comment. Yeah, and I recall seeing that. Plus, if we remain agnostic, it allows for the evolution of technology standards that emerge and not to be too tied to a specific one.
Exactly.
Yeah, great point. Okay, so we've sort of talked about the phases, which were in the area we wanted to make sure everyone had a chance to weigh in on. In hearing the comments, let's continue onward. Anna, do you want to take us to the next one?
I can, yes. The next several I had, Pamela, were those that you've raised so far, so thank you for bringing them back up. So moving on to another one is back to phase 2. There's a recommendation that it may not be necessary to have a phase 2 and moving straight to phase 3, but it sounds like based on this conversation that it's we've clarified that it's meant to be flexible and that individuals or HIEs can start with phase 3. So
and we can add language here that to Ben's point as well, that makes it more clear that it isn't a progression. It's more, ideally the phases are available, but where we would prefer is essentially to take advantage of the technology that exists, which would be in phase 3.
So the last comment I wanted to make sure we get to discuss today, Nikki, it's in 3D 3A. Or sorry, regulation 3, section D, subsection 3. Okay, yeah, and right where you are at the beginning of page 25. If you can scroll down a little bit, Nikki. To the very top of page 25. There we go. And this is the 5 business days. So as the regulation states, HIE should update a consent status every 5 business days. Instead, HIE should update consent statuses prior to exchanging patient information. This will alleviate unnecessary consent updating when no transactions are taking place. And ensure that up-to-date information is available when a transaction is taking place. So we just wanted to talk through the feasibility of HIEs updating consent statuses every 5 business days to receiving the information when they begin, right before they exchange information. So what additional technology options may be needed for providers to receive opt-out statuses on a not every 5 business days basis?
So I'll share that this was something really important to our folks because doing like a real-time call would absolutely cripple the system. Right. We exchange like millions of things through Care Everywhere, a week, and the idea that we would have to do a real-time call before any of that is exchanged wouldn't work. So we're actually really in favor of this idea that it would just be on a regular basis. We'd ingest the information and obviously implement it, but the real time I just don't think is technologically feasible.
Yeah, I agree. I mean, we heard that quite a bit. We heard that quite a bit. Pamela, is 5 days reasonable, or would you say it's really 3 or it should be 12?
We felt comfortable with 5.
Okay.
I can't speak to 3. I don't think we need 12. 5 worked, but I'd have to go back to our folks.
Anyone have any difference in terms of timing? Okay, it seems like folks are saying 5 days is probably okay. Yeah, there's challenges with real time, and defining real time, as we were talking to HIEs, is an issue, because is real time up to the second? I mean, that was some of the feedback. So there are also standards about what defines real time on a transaction. So it made it a lot easier if as part of the consumer education, patients understand that that when you opt out, there's a 5-day lag not much different than if theoretically if you opt out by sending in an opt-out form to an HIE or to your provider. So I think the industry has come to realize that we're not at real time yet, and it's probably, we just haven't heard a lot of people grousing about that.
This is Dwayne Ginners from DIN again. My concern is when there's all these patients from us, we're not seeing very many messages that really apply for us. We're in Delaware. So, so how from what I'm seeing, how does the patient know that they need to give this disclosure? How do they know this is regulated information? They might get this care a year ago, and they might not know it even being blocked at this point. So that when you talk about the 5-day lag, well, how do they even know to fill out this form?
So there's the requirement of the HIEs, and some of the HIEs are also software vendors, to have communicate to the patients. Some do through their notice of privacy practices. Others use the communication during the registration process, and yet others often have it at the provider side regarding the patient's participation in an HIE. So there are different methods of education and awareness building that are used. And sometimes patients will just go onto the HIE. They'll be familiar with it. A provider will say, to opt out, here's the website to CRISP. And you can go there to opt out. So it starts with patient education. The mechanism for that can vary.
Be some information provided to the patient when they receive this care that this is part of the system to choose whether this information.
Yeah, and it does occur. For example, you said you're in Delaware?
Yes.
So are you part of the DIN up there?
Right, DIN, right.
Okay, I'm pretty sure, I thought DIN, Jan had said before, Jan Lee, that information is provided to providers that communicate to their patients about their participation in DIN and what steps the patient would take if they chose to opt out.
Right. Yeah, we're working on that system. So, but the question is only going to apply to certain patients. It's not all the patients, because we have people in Delaware that never go to Maryland. And so trying to come up with a reasonable system for how often to communicate this to patients. This applies to patients receiving care in Maryland, correct?
So it's care delivered for a patient or provider in Maryland, correct?
Right. So we have no idea whenever some Delaware resident decides to go to Maryland for care. So we have no idea ahead of time. So that's a little wrinkle in this related to the fact that there's different states and different residents, different populations.
Right, and in your case, Dwayne, because the HIE does treat Maryland patients, and it is connected with CRISP already, that functionality you would, by implementing phase 3 or phase 2 or phase 1, you would have access to that information. So you would know if the patient chose to opt out in Maryland.
Right, but we wouldn't know to give that patient the opt-out option or to give them the information that there is an opt-out and opt-in option until they actually received care in Maryland. Because we have no idea that a Delaware resident is going to go to Maryland for care. So I just want to make sure that we're covering our bases here, and providing this information to people who receive care in a timely manner, and then they were aware of it to meet the regulations.
That is very true. You would communicate that, because DIN already has a pretty solid opt-out process and back in, and so does CRISP and other HIEs operating in Maryland. You would most likely, if when the regulations become effective, enhance your consumer education information regarding the opt-out functionalities that are available for care delivered in Maryland, and for opting out more broadly to HIE sharing that originates in Delaware. So there would be some modification to your consumer education regarding opt-out. And it would be unique to what worked for DIN and its customers, if you will. As a traditional, DIN functions more as a traditional HIE.
I understand. We're working more to try to figure out the best way to do it, certainly. Thanks.
Good comment. Thank you.
I think we had a comment from Laurel from Meditech, if HIEs are checking all patients every 5 days.
HIEs checking all patients. So is the question specifically, is it just an update they're looking for, or is it, if the CSV file, I'll just play on that for a moment, had 1,000 patients, you'd want to only see what was new over the last 5 days? Or is your question, is it more you would just take the entire file? Was that your question?
I think partially that's the question. Okay. The other part is, you consider the historic database of patients and the volume of that, patients updating their criteria. That's going to potentially cause as much of a burden as real-time checking.
Yeah. No, I would imagine, and this is where we would look to Chris in terms of developing how the functionality of each of the phases is essentially built out. There was discussion a year ago about can it just be an extract of what's new between this range of dates, or does it have to be the entire database? Because your point is a good one. Over time, it can be quite large. The thinking, and I'll look to Nicole to correct my response if I'm not correct, and that was you would have the ability to use a date range capability as opposed to consuming an entire database.
And I would just put in another plug for folks that want to pilot this with us as we're kind of figuring this out and figuring out the specifications like that.
Great question. Maybe there's a volunteer.
I was hoping.
Other comments here? Okay, Anna.
So we've made it through the comments that we wanted to go through today, but before we move away from the regulations, I just wanted to see if there are other comments that HIEs in particular have that regarding the consent management application and these regulations.
And if we didn't share a point that was specific to you, we tried our best to generalize the comments, but feel free to ask it now, or you can reach back out to us and we'll be happy to respond to you individually equally. This isn't the only opportunity, as you know, for you to make comments. Ideally, once the regulations are proposed, you would take advantage of the comment period and submit comments. What we will do is any changes that we make, we'll absolutely just sort of share them in advance. We might not be able to have a working session given the timing, but we would be open to comments coming back to us. Said differently, this isn't really a one and done approach. We are trying to do it in an evolutionary state, and that's the way we want to treat each one of these working sessions. So your comments are valued and greatly appreciate you taking time to offer them. So getting back to Anna's point, are we missing anything? Is there something we need to focus more directly on? Do you think we're about right, if you will, in our design of the regulations? Would you say, oh, we've missed something completely?
David, the only thing I would say is that the comments that you guys absorbed earlier do have implications in other provisions. So for example, if we're going to decide that we aren't going to push, HIEs aren't going to push opt-outs received locally to the state designated HIE, then I think B needs to go away. And then I also think the idea that we discussed earlier about the, query and the concerns that we'd expressed about having to kind of go out and get a file. I worry about phase one. I mean, what Nicole said about, that we may be able to skip phase one is fine, but I do worry about this idea that we might be living in a world where HIAs have to go get a file from CRISP, which it seems like is what phase one was about. So we talked about all these things. I just was mentioning that I think there's those comments sort of reflected other places too.
Yeah, excellent point. Thank you, Pamela, for your feedback. Anyone else have any last thoughts?
Hi, this is Nicole Sweeney again. I'm just, always going to put in a plug. I think for in all of these calls for this, I think provides us another opportunity to get very tight on our consumer engagement and potentially centralize it. I know the regulations require HIEs and providers to have patient education and consumer education. I think there's a great opportunity, especially with this new functionality, to make that more centralized and more comprehensive. So even if it doesn't end up in regulation, I am here with the Consumer Advisory Council to help make that happen if folks are interested in engaging. And I would love for it to also come in some regulatory or sub-regulatory guidance too. Thanks.
Yeah, and Nicole, excellent, thank you. And to Nicole's earlier point, if there are HIEs or other policy folks on the call here today that would like to work with CRISP during a piloting phase, please do reach out to Nicole. Okay, Anna, next steps.
All right, so I am going to share the slides again. We can talk through next steps. So thank you everyone for your thoughtful input on the regulations. So staff will consider the feedback to the informal draft amendments, and we may seek additional input from HIEs on potential changes as we're working on those drafts. We aim to publish the draft regulations in the Maryland Register in the fall of this year. And so you may hear follow-up emails from us or additional questions from us for seeking clarification as we work to incorporate your feedback. So as I mentioned earlier, the MHCC will host 2 additional working sessions to discuss the other provisions of the draft regulations. So next Tuesday, July 23rd at 1:30, a similar working session will be held on the reporting of non-controlled prescription drugs to CRISP as required by Chapter 296, Public Health State Designated Exchange and Health Data Utility. And as I mentioned, I believe many of the dispensers on the call will find this conversation particularly interesting. And then in 2 weeks, on July 30th at 1 p.m., we will have another similar discussion on the reporting of electronic healthcare transactions as required by Chapter 790, 791, Public Health State Designated Exchange, Clinical Information. And many of the electronic health networks on this call may also find that conversation particularly interesting. So I shared the links to register for these meetings in the initial email, but I will follow up with a reminder as to where to register for these calls.
And we'd like to invite our executive director to make comments at this point.
So thanks again for everyone who attended. The kind of walk away point, I think, was in terms of the phases that we saw them as evolutionary. But if the folks on the call think that it's not feasible and at every phase you're essentially starting over, we'd like to hear that because obviously that's not our intent. And we'll be interested in going back and refining that further. But I want to thank everyone for their attention and thoughtful comments. Have a good afternoon.
Thanks, everyone.
Thank you.
Have a great day.